I am so pleased and grateful that the 12 distinguished individuals before us have agreed to share their voices and experience and the wisdom of their communities during this historic time. So let us move now to the formal swearing in of our task force members. I want to welcome all who will serve as the inaugural voting members of the COVID-19 Health Equity Task Force. Ms. Mayra E. Alvarez, President of the Children's Partnership. Dr. James Hildreth, President and Chief Executive Officer of Meharry Medical College. Mr. Andrew Imperato, Executive Director of Disability Rights, California. Mr. Victor Joseph, immediate past Chief Chairman of the Tanana Chiefs Conference. Dr. Jone Khaldun, Chief Medical Executive for the State of Michigan and the Chief Deputy Director of Health for the Michigan Department of Health and Human Services. Dr. Octavio Martinez, Executive Director of the Hogg Foundation for Mental Health at the University of Texas at Austin. Dr. Tim Putnam, President and CEO of Margaret Mary Health. Mr. Vincent Taranzo, an active student from Broward County, Florida. Ms. Mary Turner, an ICU nurse at North Memorial Medical Center in Minnesota. Dr. Homer Venters, Clinical Associate Professor at the New York University College of Global Public Health. Mr. Bobby Watts, CEO of the National Healthcare for the Homeless Council. And Ms. Haeyoung Yoon, Senior Policy Director at the National Domestic Workers Alliance. I now ask, as part of the swearing in, that you please raise your right hand and repeat after me. I do solemnly swear.
I do solemnly swear
That I will support and defend.
I will support and defend
The Constitution of the United States.
the Constitution of the United States
Against all enemies, foreign and domestic.
against all enemies, foreign and domestic,
That I will bear.
that I will bear
Through faith and allegiance to the same.
to the faith and allegiance to the same,
That I take this obligation freely.
that I take this obligation freely
Without any mental reservation or purpose of evasion.
without any mental reservation or purpose of evasion,
And I will well and faithfully discharge.
and I will well and faithfully discharge
The duties of the office.
the duties of the office
On which I am about to enter.
on which I am about to enter.
So help me God.
So help me
God.
So congratulations, task force members. Thank you again for volunteering your time and for all the work that you'll be doing. I now turn it back over to Captain Samuel Wu from the HHS Office of Minority Health. Thank you again.
Thank you, Admiral Collins. Congratulations again. So now I will conduct a formal member roll call. This is for the meeting record. When I call your name, you may respond with present. Mayra Alvarez.
Present.
James Hildreth. Okay. Andrew Imperato.
Present.
Victor Joseph.
Present.
Jone Khaldun.
Present.
Octavio Martinez.
Present.
Marcela Nunes Smith.
Present.
Tim Putnam,
Present.
Vincent Torrenzo,
Present.
Mary Turner,
Present.
Homer Benters,
Present.
Bobby Watts,
Present.
Heyang Yoon.
Present.
Madam Chair, we have a quorum.
Thank you, Captain Wu. So congratulations, everyone. And so it's wonderful for me to be able to take this moment now and present the task force charge. The COVID-19 Health Equity Task Force was established by Executive Order 13995, entitled Ensuring an Equitable Pandemic Response and Recovery. This executive order was issued on January 21st, 2021. The task force is part of the government-wide effort to identify and eliminate health and social disparities that result in disproportionately higher rates of exposure, of illness, hospitalization, and death related to COVID-19. Vice President Harris set a blueprint for how to advise this commitment during her time in the Senate. And there she introduced the COVID-19 Racial and Ethnic Disparities Task Force Act to bring together healthcare experts, policy experts, community-based organizations, as well as federal, state, local, tribal, and territorial leaders to inform a data-driven and equitable response to the pandemic. So this task force is responsible for providing specific recommendations to the president through the coordinator of the COVID-19 response and counselor to the president for mitigating the health inequities caused or exacerbated by the COVID-19 pandemic, and also for preventing these kinds of inequities in the future. So this includes recommendations on how agencies, states, local, tribal, territorial officials can equitably allocate COVID-19 resources and disperse relief funds. In addition, the task force will provide recommendations for effective outreach and communication to minoritized populations, as well as the hardest hit communities, and on how to improve cultural responsiveness within the federal government. In accordance with the relevant presidential memorandum, the task force will also provide specific recommendations for advancing cultural responsiveness, language access, and sensitivity towards Asian Americans and Pacific Islanders in the context of the federal government's COVID-19 response. So data, as we've already been discussing, is also a specific focus of the task force charge. As many of you already know, the limited availability of data by race, ethnicity, geography, disability, and other factors has delayed the recognition of risk among many of these groups, as well as the development of targeted responses. So as a group, we will begin this work to close those data gaps today. So overall recommendations will advise on efforts to improve data collection and use, as well as a long-term plan to address data shortfalls regarding communities of color and underserved communities. This includes addressing data challenges that relate to data intersectionality in order to better prepare a response to future pandemics. So the work of the task force will conclude after issuing a final report to the COVID-19 response coordinator on the drivers of observed COVID-19 inequities and actions to ensure that future pandemic responses do not ignore or exacerbate underlying health inequities, as well as the potential for ongoing disparities faced by COVID-19 survivors. So the function of the task force is solely advisory. Today, our working topic is data needs to drive equity in the COVID-19 response and recovery. The work of the task force should and must be guided by data. Ensuring we have high quality, comprehensive data is absolutely essential for understanding exactly how the pandemic is affecting particular communities, ensuring our strategies moving forward address health equity and target those communities bearing a disproportionate burden of risk and disease. I want to thank now, in addition to the federal government and local municipalities, but also investigative reporters, foundations, researchers, and others who have been at the forefront of gathering and disseminating data. We will hear from two guest speakers today, Dr. Krieger as well as Mr. Dawes, to help frame our discussions and deliberations on the data needs to drive equity in the COVID-19 response and recovery. Just a few words about the people serving on this group. I am just honored, excited to work with all of you who have been selected as the non-federal members on this group. You were identified through conversations with stakeholder groups, recommendations from so many organizations and individuals, and just through the visible effort and expertise you have lent to all of your communities in the fight against COVID-19. In addition to the experience and expertise that you bring to this work, you collectively represent a range of just key voices and constituencies from across the country. So in addition to the group that's gathered here today, I've also asked additional federal agencies to be represented on the COVID-19 Health Equity Task Force as federal members in subsequent meetings. And so this includes representation, not limited to, the Departments of Agriculture, Education, Health and Human Services, Housing and Urban Development, Justice and Labor. Just offering critical perspective on some of the most effective levers that can be pulled in this whole of government effort for COVID-19 health equity. Just want to take a moment to acknowledge the federal staff who worked to stand up this task force in record time. This team supports our day-to-day operation and management. Thank you so much to Captain Sam Wu, the designated federal official, to Ms. Bonnie Mason, to our co-executive directors, Dr. Martha Okafor on detail from the Administration for Children and Families, and Ms. Alexandra Huttinger on detail from Health Resources and Services Administration. Thank you to Ms. Sharice Perry and Ms. Caitlin Pennington and Commander Josephine Nguyen, the White House Fellow. So finally, it's important that everyone see themselves in this work. The White House will continue to engage with stakeholders and bring additional voices. And public comment at task force meetings, very important, just additional ways to hear from others with lived experience and expertise. So with that, I will stop. We are charged. I will welcome the Honorable Jeffrey Zients, coordinator of the COVID-19 response and counselor to the president. Mr. Zients, thank you for joining us today, please.
Well, Jeff, please, and I've never been honorable, so.
Oh, please.
But I'm honored to be here, I'll tell you that for sure. And I feel every day incredibly lucky that Dr. Nunes-Smith is leading these efforts. I mean, A+++, and A++ attracts A++, so thank you for all of you for joining her task force. I'm just gonna jump in here for a few minutes, but I didn't want to miss the opportunity to introduce myself. Again, Jeff Zients, and I'm the White House COVID coordinator. And I'm really, really excited to know that this group is here and is getting going. Today is actually the coming together of a vision that the then Senator Harris had. I think it was almost a year ago. Is that right, Dr. Nunes-Smith? I mean, that took a lot. She had foresight, and thankfully she's our vice president, and with President Biden's leadership. But that turned into a legislative proposal that we took executive action on the first full day of the president's and vice president's administration. He signed an executive order that created this task force, and I think that's just one of many actions he has taken, and the vice president and the president will take to ensure that efficiency and speed of COVID response are really, really, really important, but equally important is equity and fairness. And just last week, we had a whole dedicated session in the Oval Office on this very topic. And it's part of every one of our interactions, but we dedicated a full 45 minutes in the Oval with, with Dr. Nunes-Smith, as I said earlier, in charge. Things are moving forward as you would expect, but we're still feeling appropriately the enormity of this task, of this responsibility to make sure that our COVID response is done in a fair and equitable way. And we're being held account in a very good way for that. So all of you are going to be essential for helping us figure out the right tactics, strategies, and approaches to ensuring that as we defeat this pandemic, we do it in a fair and equitable way. So I can't tell you how excited we all are to have you taking on this work. I know all of you have a lot that you do already, so we appreciate your public service on top of everything else you do. Your recommendations we look forward to. My big belief from my time in the Obama-Biden administration, I ended up serving all 8 years. My time in business before that is that the recommendations are important to get right, and then it's all about execution. And I can tell you with Dr. Nunes-Smith and Dr. Cameron Webb and our whole team, we're very committed to execution and implementation. So know that as you put forward ideas and recommendations, know that we'll be all over the execution and implementation. Dr. Nunes-Smith, anything else you want me to cover before I actually let you do some work?
Thank you so much. Although I'm hoping honorable sticks, but thank you so much, Jeff, for coming.
Thank you for being the first person to ever call me honorable. And then again, I'll end where I started, which is thank goodness for Dr. Nunes-Smith and thank goodness for all of you. It's going to make a huge difference. So we're doing all we can, and you'll give us additional ideas and direction. And don't be shy when you think that any of us are off track or missing something. That's how we learn, and that's how we get better. So not only do we look forward to your constructive recommendations, we also look forward to your constructive criticism or pointing out of what we're doing wrong or what we're missing. So thank you again for your service, and back over to you, Dr. Nunes-Smith.
Thank you so much, Jeff. So next, I want to say a special thank you to Acting Secretary of HHS, Norris Cochran, for making the time to join us today. Please, the floor is yours. Thank you.
Yes. Hello, everyone. It's great to see all of you here. I am really honored to be with you and add my voice in welcoming you as now members of this inaugural meeting of the COVID-19 Health Equity Task Force. I am here today serving as the Acting Secretary of the Department of Health and Human Services, and I am eager to become acquainted with you, to hear from each of you, and to benefit from your experience, your insight, and your counsel. As you know, the Department of Health and Human Services is a key organization in the government-wide response to COVID-19. We are fully engaged in the health and human services elements of that response and the impact that COVID-19 has had on individuals and families, communities, and governments. For example, we are supporting the development, procurement, and distribution and administration of life-saving vaccine and therapeutics and diagnostic tests. We are executing directly and through financial support and technical assistance to our many partners the elements of the public health response in the range from genomic sequencing of variants to the community level data-driven epidemiology. We support the delivery of healthcare through the Union Health Service, through community health centers, Medicare, Medicaid, the Children's Health Insurance Program, the Marketplace. We're providing relief to healthcare providers and supporting states, localities, and local organizations in a range of services, from providing food to seniors, mental health and substance abuse services to those in need, childcare, Head Start, and other social services. And in each of these areas, and really in everything that we do in response to this pandemic, health equity has to be built into the foundation of our work. It cannot simply be taken on as an added element of our response, but must be foundational. And as the President and Vice President have articulated and set out in the executive order for ensuring an equitable pandemic response and recovery, and is reflected in the foundations of your task force charter, we must address the health inequities caused and exacerbated by the pandemic and work to make permanent change to prevent such inequities going forward. We are well now beyond a year into the response to COVID-19. The challenges are substantial and the time is critical. In terms of this task force, we welcome and encourage your work in providing us advice and recommendations to inform and direct our efforts. All of the HHS, as I've outlined, is engaged in our response, and this task force is uniquely positioned to really inform that multi-pronged effort and to make a difference now and going forward. And input on our communications efforts, our data collection, resource allocation, and other areas will inform our work for both the immediate and the short and long-term actions in the interests of addressing what are severe and pervasive health inequities. So in closing, I want to again say thank you and thank the team, thank Dr. Nunes-Smith and Admiral Collins for their support of the task force and the team that pulled this meeting together and all that went into it. And thank all of you as members for your participation in this urgent and vital endeavor, and really encourage all of us to embrace the opportunity as well as the responsibility to coordinate in the interests of an equitable response to the pandemic and beyond. So thank you.
Thank you so much, Acting Secretary. We hear that. I don't care. Appreciate those comments. Next, we'll have remarks from HHS Chief Science Officer, Dr. David Kessler. We had the opportunity of being co-chairs together along with Dr. Murthy for the COVID-19 Advisory Board. Thank you, Dr. Kessler.
Dr. Nunes-Smith, it really is a very, it's just very special for me. You asked me to join you today. I want to start by thanking each member of the task force for your service to the nation and to your neighbors and your communities throughout the country. To each member individually, you know, I believe you're here. I mean, I know you're here not just because you were asked, but because you understand the toll the pandemic has had upon racial and ethnic minority and underserved populations. And one of the reasons why it's so special to be here with all of you today is because I know, and Dr. Nunes-Smith knows, we're all here today because the president really wants you to be here. Dr. Nunes-Smith and I mean, one disclosure, I think it's fair to say we became good friends. This goes back now a year, a very special year for us, when we had the opportunity to brief, on a regular basis, the president before he was president, and we got to hear firsthand from him how much he cared about health equity. We did not get through a briefing, I can tell you, without Marcella or I, or without being asked very specific, pointed questions by the president. I mean, you understand the urgent need, as he does, for all of us to come together, federal government and leaders in communities, all of us, to really ensure that equity becomes the primary determinant of health. The privilege of serving all of you, and the president is as Chief Science Officer for the COVID-19 response team. I just can't stress enough how our approach must be rooted both in science, but science and equity. And under this task force with the response team, we have the opportunity to deliver on that most basic needs for safe, effective, and equitable healthcare. We've been at this about a month. We are seeing, I think, important progress in delivering vaccines in the country. This is encouraging, but as you know well, as you know, as we know intimately, there is an enormous amount of work to be done as we accelerate the work with the vaccine and therapeutics. I look forward to engaging substantively on a whole host of issues on the inclusion of communities in clinical trials, in making sure there's equitable distribution, enhancing that distribution in vulnerable communities. But we will do that, I am told, at future meetings. I joined you today to say that I look very much forward to your work. I look forward to working with all of you. We cannot be successful if success is not experienced by everyone. The task force comes at a time when science aligns perfectly with the opportunity to create new and equitable possibilities for health and well-being. And together, we will make, I am sure, you will make that difference that has been needed for far too long. Dr. Nunes-Smith, thank you for inviting me for a few minutes to join me.
Oh, thank you so much, Dr. Kessler. Really appreciate you as well making the time to join us today and for all you're doing. So next, we would like to hear from and welcome Acting Director of the Office of Minority Health, Rosalind Moore. And before you start, I just again have to say a special thank you. I think awards should be dispensed for how quickly the Office of Minority Health got us stood up. And so just thank you so much, Acting Director Moore, for all the support from the office.
Thank you, Dr. Nunes-Smith, and it was a pleasure. Good afternoon to everyone. Today, we witness the convergence of individual and collective leadership and an opportunity to shift the narrative about health in America from the archives of disparity to a legacy of equity. On behalf of the Department of Health and Human Services Office of Minority Health, I want to thank you for your willingness to serve as a COVID-19 Health Equity Task Force member. By statute and mission, our office has a distinct responsibility for promoting the health and well-being of racial and ethnic minority populations. Our portfolio is laser focused on policy and data that help us understand the disparities experienced by socially vulnerable individuals, with the direct intent of identifying pathways for achieving and sustaining health equity across all populations, locations, and conditions of life. As the pandemic continues to be in the national forefront, partnership and strategic investment are key. We've been able to align federal resources with state and local efforts to link diverse communities to COVID-19 information, services, and resources. But we know more is needed. The Office of Minority Health is honored and fully committed to support you in your charge to synthesize information, offer recommendations to help us understand how to mitigate inequities related to COVID-19, and more importantly, to prevent any such inequities in the future. During this pivotal moment, a time when knowledge, commitment, and need are seamless, the Office of Minority Health stands with you, ready to accelerate what's possible to ensure that the agenda for health equity becomes a shared reality. Much appreciation for all that is to come. Thank you very much for today.
Thank you so much, Acting Director. Really appreciate that. All right, so it's time that we hear from our task force members that we are so eager and happy to be working with and so grateful for your service. I will turn now and give each of you an opportunity, please, to introduce yourselves to everyone who is joining us today. I will ask, let me see, Dr. Tim Putnam to please get us started.
Thank you, Madam Chair. It's a pleasure to be part of the task force. I'm president of Margaret Mary Health, a community hospital in Batesville, Indiana, and I have the honor of working with a lot of good and solid healthcare professionals in rural America. I'd like to bring to the task force the perspective of someone that was running a community hospital, what it was like dealing with the challenges early in the pandemic when we didn't have the data that we needed. And I think that's really important going forward to have that information. I also like to bring a perspective. My background is an EMT, but most of all, I think it's to represent and recognize the challenges the good people of rural America have faced with regard to health equity. I think that's really important. I've heard from so many of my colleagues on that. I'm proud to work with the members of this task force, and especially glad to have the experience and perspective of Vincent Toronzo. Vincent?
Thank you, Tim. I really appreciate it. Good afternoon, everyone. My name is Vincent Toronzo. I'm from Pembroke Pines, Florida, and I'm honored to serve alongside Dr. Marcella Nunez-Smith and my esteemed colleagues to address COVID-19 related inequities. I have experience with the inner workings of local government, where I was able to serve with city management on various municipal projects. I also serve as the state secretary of the Florida Association of Student Councils, where I've been advocating for the inclusion of student voices in this community, and such as assistance to foster children and the assurance of students' safety amidst the COVID-19 pandemic. As a Latino, I have seen firsthand on how Hispanic populations and people of color are being disproportionately affected by the COVID-19 pandemic. As a young person, I understand that our country strongly supports the idea of young people having a voice in all levels of government. So thank you very much, and I look forward to working together so we can ensure a more equitable response for this pandemic. I'll hand it off to Mary Turner.
Good afternoon. My name is Mary Turner, and I am president of Minnesota Nurses Association, which is a proud affiliate of National Nurses United, and I live in Plymouth, Minnesota. Tonight at 2300, it will be exactly 1 year that I have been on the front lines of this pandemic. In the medical ICU at North Memorial Medical Center in Robbinsdale, Minnesota. I remember that night coming onto my floor and being immediately surrounded by my coworkers. I saw anger and disbelief on their faces as they asked me, "Is this true, Mary, that we get one N95 and we have to use it till it disintegrates off our faces?" My heart sank as I recall glancing around my unit and already seeing the beds filled with ventilated, isolated COVID patients. When I looked back to their faces, I saw something else. I saw fear. I'll never forget that moment when one young nurse asked me, "How will I be able to safely go home to my children in the morning?" Make no mistake, this kind of conversation was repeated over and over all across our nation as healthcare workers tried to come with grips with what was ahead of us. So why am I here? I'm here to bear witness to the realities of what we on the front lines have experienced over this past year with all the pain, suffering, and death. I will also testify to the fact that every bit of data illustrating inequities brought forth by this pandemic, I have seen with my own eyes in my ICU. To all the healthcare and frontline workers across our nation, I vow to do whatever I can do so that we never have to endure a year like 2020 again. Thank you. And I now pass it off to Homer Venters.
Hello, my name is Homer Venters. I'm a physician and clinical associate professor at the NYU College of Global Public Health, and my hometown is in Port Washington, New York, and I'm thrilled to be here. I've spent my career focusing on promoting health among incarcerated people and documenting how incarceration can harm health. I'm thrilled to be part of this task force and advance what I've learned in the past year regarding COVID-19 in jails, prisons, and immigration detention settings. That includes the lack of data regarding whether CDC guidelines are being implemented, whether people receive the care they need, and whether people in these congregate settings are being prioritized for life-saving vaccines. I thank you again for the opportunity to participate and contribute, and I want to hand it off to my colleague, Bobby Watts.
Thank you, Dr. Venters. I'm Bobby Watts, the CEO of the National Healthcare for the Homeless Council, and I live in Goodlettsville, Tennessee. And I bring the experience of working with people experiencing homelessness for 30 years in a number of different settings, and 25 of those years working in a federally qualified health center that focuses on meeting the needs of people experiencing homelessness. I've seen how mass homelessness in this country is the result of the failure of almost all of society's systems, and each of these failures is usually rooted deeply in inequity. So I bring that perspective of the community health center movement and also the knowledge and the collective experience and expertise of thousands of clinicians and administrators working on the front line, meeting the needs of vulnerable populations, and most importantly, of the patients with the lived expertise of homelessness themselves. I'm deeply honored to join with all of my colleagues and the administration in forming an equitable response that leaves no one out. And I turn it over to my colleague, Hae-Young Yoon.
Thank you. My name is Hae-Young Yoon. I'm the Senior Policy Director at the National Domestic Workers Alliance. I'm really humbled to be part of this task force and first most to learn from all of you. I have nearly 20 years of experience of working with low-wage immigrant workers where our country took a global pandemic to recognize as essential workers. These are low-wage workers who are working in many of our service industries, who are running our economy in times of crisis, but also in times of stability. And I think it also took a pandemic to realize that many of the working families who are keeping our economy going are falling through the cracks, right? So much of the health equities connected to the economic inequities that they've been facing even before the pandemic. So I am really humbled to be part of this task force, to work with all of you, to put forth recommendations where no one is left behind, that every working family that our economy, our nation is delivering for every single working family in this country. Thank you so much. And I turn it over to Octavia Martinez.
Thank you, Hae-Young. I'm Dr. Octavio Martinez. I'm the Executive Director of the Hogg Foundation for Mental Health, which is part of the University of Texas at Austin. I live in a little south of Austin in Comal County, part of New Braunfels, Texas. So kind of bringing a little bit of the rural perspective to the work that we're going to do as a task force. But two things perspectives that I bring and add to the wonderful things my colleagues here on the task force have already mentioned. I bring a mental health perspective, psychiatrist by training, and as a physician, and as the head of the Hogg Foundation for Mental Health, where we have been really concentrating on and recognize, and I hope you recognize and understand how important our mental health is and how it's being currently just really tested by this pandemic. And it's affecting those from the very young to the very old. No one is being spared. And it will be ongoing, even beyond the current crisis when it comes to mental health needs that we need to take a look at. The other one is I'm also trained in minority health policy many years ago, and have worked from a public health perspective for quite a long time, over 20 years now, trying to eliminate health disparities and also workforce disparities, but also trying to also bring to the table for us to understand how the social determinants of health, the social determinants of mental health are so important in addressing those, and also the political determinants of health. With that, let me now turn it over to Mayra Alvarez.
Thank you, Octavio. Good afternoon, everyone. My name is Mayra Alvarez. I have the honor of serving as president of the Children's Partnership. We are a California policy and advocacy organization focused on advancing child health equity. I live in the great city of San Diego, California, and our organization is based in Los Angeles, California. I bring with me to this role my commitment to ensuring every child, regardless of their background, has the opportunity to grow up healthy and thrive, and a recognition that children are part of families, and families are part of communities. Coming from a state as hard hit as California and representing a Latinx community that is dying from COVID-19 at an alarming rate, I am honored to do all I can to ensure our work to advance equity in our nation's response centers the needs of Black, Indigenous, and people of color, the communities that are not only disproportionately impacted by COVID, but are also on the front lines, working many of the jobs that are helping keep our economy running and supporting the many of us privileged enough to work from home. As a proud daughter of Mexican immigrants, I am honored to bring my personal and professional experiences to the critical work to be done alongside my fellow task force members, Chair Nunes Smith, and partners across the country in ensuring a more equitable national response to COVID-19. Thank you. And now I will hand it over to my colleague, Andy or Andrew Imperato.
Thank you, Myra. It's great to be here with a fellow Californian. I'm coming to you today from Sacramento, California, where I am the Executive Director of Disability Rights California, and we're a statewide legal services advocacy organization with people of all types of disabilities across the age spectrum. And I do want to give a shout out to people over 65 as part of the mission of our task force. Discrimination happens in a lot of different ways, and oftentimes ageism and ableism happen together. So I'm grateful for the opportunity to work with people here in California on a master plan for aging. And there was a whole equity component to that plan that I'm hoping we can all look at as we embark on our work. My career has been really focused on disability rights from a policy perspective. Before coming to Disability Rights California, I worked for Senator Tom Harkin in the U.S. Senate Committee on Health, Education, Labor, and Pensions as his disability policy director. And like Dr. Martinez, I have kind of expertise in mental illness, but in my case, it's based on my lived experience with bipolar disorder, which has certainly informed my work. And the last thing that I'll say is at Disability Rights California, we're very focused on the intersection between disability and other marginalized groups. So I'm really excited to work with the folks on this task force and the expertise that's been assembled to really look at some of those intersectional issues as we have a conversation about health equity. And now I get to turn it over to Victor Joseph.
Thank you. Victor Joseph. I'm a tribal member of Native Village of Tanana. As a tribal leader and as a tribal member, I have firsthand knowledge of the disparities and the challenges faced by the American Indian Alaska Native people. As the former chief chairman of Tanana Chiefs Conference, that's our service area that covered about 50,000 miles less than the state of Texas and 37 communities. I assisted in not only helping our corporation, our organization, but our tribes and tribal communities respond to the pandemic. Many of these communities lack the basic infrastructure to even follow the guidelines that was initially put forward. Wash your hands, maintain distance. This was an impossibility with many of our communities, and that was a major challenge. My commitment to this group is to help end the disparities that our people face and move forward. Thank you all very much, and it's an honor to be on this committee. And I turn it over to Jonay Khaldun. Sorry about that.
Thank you. So my name is Dr. Jonay Khaldun. I am a native of Ann Arbor, Michigan, and I currently serve as the Chief Medical Executive for the state of Michigan and the Chief Deputy for Health in the Michigan Department of Health and Human Services. I've also had the honor of working on the front lines in the emergency department as an emergency medicine physician at Henry Ford Hospital in Detroit. I'm just truly incredibly honored to be a part of this task force. Over the past year, I've also been the lead strategist for my state's public health response to COVID-19, including our efforts to address disparities and inequities. And like everyone else across the country, Michigan very early on saw these disparities play out, where Black and Brown communities were hardest hit by this pandemic. For example, African Americans make up about 14% of Michigan's population, but early on there were 32% of cases and 40% of deaths. But we took action, and we were able, actually, over the span of a few months, actually see a significant decrease in that disparity. And so what that tells me is that with intention and with focus, you actually can address and eliminate these disparities. So again, I am so grateful for the opportunity to be on this task force at such a pivotal time in our nation's history. So thank you, and I'll turn it back over to Dr. Nunez-Smith.
Thank you so much, Dr. Khaldun. Everyone brings just so much to the work. It is inspiring and motivating anew just to hear everyone and what you're contributing already and will bring. You know, as I mentioned at the top, we are leaning right in to the data challenge and hopefully the data opportunity as well. So I'm really grateful to have just two luminaries in the field with us today to be able to help shape our conversation and our thought moving forward. You know, first I'm going to introduce Dr. Krieger, and I have to be really clear that for both Dr. Krieger and Mr. there just aren't enough words yet in the English language to describe all their accomplishments, so it will be brief introductions that won't do them justice. But I will introduce Dr. Krieger, who will share with us all that she has been doing and her team leading and helping give us some frame for this conversation around data. After Dr. Krieger's sort of formal slide presentation, we'll have some time for question and answer from all of you task force members. And then I will introduce Mr. Dawes. So without further ado, let me attempt to introduce Dr. Nancy Krieger. So Dr. Krieger is a professor of social epidemiology, as well as the American Cancer Society clinical research professor at the Harvard T.H. Chan School of Public Health, as well as director of the Harvard School of Public Health Interdisciplinary Concentration on Women, Gender, and Health. She is internationally recognized, most absolutely, as a social epidemiologist with a background in biochemistry, philosophy of science, and history of public health, plus 35 plus years of activism involving social justice, science, and health. She's an ISI highly cited scientist. This group comprises less than 0.05% of publishing researchers. And Dr. Krieger's work addresses, first conceptual frameworks to understand, analyze, and improve the people's health, including her eco-social theory of disease distribution, focused on embodiment and equity. Second, ideologic research on societal determinants of population health and health inequities, including structural racism and other types of adverse discrimination. And third, methodologic research to improve the monitoring of health inequities. So with that, we are so very fortunate and grateful to have you join us today, Dr. Krieger. Please, the floor is yours.
Thank you very much. Let me share my screen. Thank you very, very much for including me at your first meeting. This country needs your work more than ever, and I'm honored to be with you today. Today, I'm going to speak briefly on health inequities in COVID-19, data gaps and solutions. And I begin, as I do for all my talks, by acknowledging that as a US person in Boston, I am on Indigenous lands and I pay heed to critical Indigenous thinking. I was asked to be frank and bold, and my 4 key points are: first, there are terrible inequities, as we have already heard, reflecting structural racism and social injustice, and who is being exposed to the virus that causes COVID-19 on account of their working and living conditions, and these inequities can be prevented. At issue is who can versus cannot afford to work from home, let alone has a home, and if they do, has space to self-isolate if infected, and if an essential worker who does versus does not have safe working conditions, paid sick leave, and adequate personal protective equipment. Second, there are terrible inequities as who is more likely to die if infected, reflecting pre-existing societal, economic, and contingent health inequities. Third, there are widespread inequities in vaccine rollouts, compounded by long-standing inequitable practices of medical and public health institutions that impede access and harm trust. And fourth, there are terrible problems in how the data are being reported by public health agencies, which makes it hard to see and address these inequities. Remember, as you look at these data taken from the Hopkins website from February 23rd, the sorry day when the US, long worst in the world, reached over 500,000 deaths. Remember that every tested person, every one of the 28 million confirmed cases, has worried about what will happen, as have their families and friends. Every one of the now 500,000 dead rendered in this panel of cascading deaths over time have families, networks, and neighborhoods who are grieving, translating to millions affected. Rates of both hospitalization and deaths, as we heard, are 2 to 3 times higher among the US non-Hispanic, Black, Latinx, and Indigenous versus white non-Hispanic populations, with these inequities highest among working age adults. And for vaccination, just taking one example from the snapshot of Alabama, alphabetically, on February 16th, whites were overrepresented and Black and Latinx populations underrepresented relative to cases, deaths, and total population. Meanwhile, data are scarce to non-existent on COVID in relation to occupation, education, income, disability, sexual orientation, gender identity, let alone community context or incarceration. Nor do these data tell a self-evident story. A crucial first point is that data, contrary to its etymology, is never a given. Despite being the past participle of the Latin verb dare, to give, data are always produced by people, revealing what they observe, fail to see, or suppress. And in the US, when it comes to health inequities, there are long histories of contested production and use of racialized data. Starkly, the contrast is in service of scientific racism and eugenics versus for social justice and equity. The two-edged sword of data is sharp. Edge one is the problem of no data, no problem, and the denial of and any ability to prove that the problem exists. Edge two is that problematic data, whether wrongly conceived, wrongly used, or both, can be a huge problem. Endless reams of US health reports and studies routinely use racialized data, but include no data on racism, leading to observed differences endlessly being attributed to alleged genetic differences, individual behaviors, or deficient cultural mores. And meanwhile, keep in mind the actual point, which is, what are the data needed to secure health justice? So edge one first, no data, no problem. During the first terrible months of the pandemic in the US, you could barely find any federal government COVID-19 data by race ethnicity, despite it being a standard variable for just about every other health outcome, and none by socioeconomic position. Instead, in this early period so crucial for understanding and altering the course of this pandemic, data journalists led the way in piecing together the evidence, illuminating both data gaps for and greater burdens among populations of color. In response to public outcry on June 4th, a new regulation mandated reporting racial ethnic data by no longer than August 1 for COVID-19. However, on September 16th, my team and I checked the CDC website and found that racial ethnic data were still missing for 43% of the COVID cases added between August 28th and September 16th. Earlier this month, we checked again on February 4th, and for the cases reported between December 2nd, 2020 and February 3rd, 2021, fully 33% were still missing these data. Moreover, missing yet another opportunity to get it right in this country, on February 1, CDC reported that racial ethnic data were missing for 48.1% of persons vaccinated against COVID-19 in the first month of the rollout, December 14th, 2020 to January 14, 2021. But only 0.1% and 3% were missing data respectively on age and sex. Once again, there has been a public outcry. And to this day, most COVID-19 websites and reports continue to lack economic, occupational, community, or other contextual data, leaving the decontextualized data open to narratives of victim blaming. Moving on to edge two, the initial response of CDC to the outcry about missing racial ethnic data was to focus on proportions, not rates, comparing the racial ethnic composition of COVID deaths versus that of the total population. Initially, the death data were on one website, those for the total population on another, making it very difficult to discern quickly if the proportions differed. But worse, the data made no sense because contrary to the reports coming from the field, the CDC's data were suggesting that the white non-Hispanics were overrepresented among COVID-19 deaths and Black Americans were underrepresented. Working with some doctoral students to figure out what was awry, we realized that the CDC had committed a classic type 3 error, right answer to the wrong question. In brief, the CDC weighted the denominators for US counties by the percent of total COVID-19 deaths occurring in that county in the state. Given who was hardest hit by COVID-19, the net effect was to deflate the denominators for the white non-Hispanic population and inflate the denominators for the other populations of color, thus inflating the risk for the former and deflating the risk for the latter. Why did the CDC do this? The stated reason is that they were concerned that the racial ethnic composition of the places initially hit hard by COVID-19, especially New York City, differed from that of the areas hit less hard. And they said they sought to quote unquote correct for this by their weighting procedure. But to ask and answer the question, how does racial ethnic risk for COVID-19 mortality vary apart from how racial segregation affects who lives where, is to ask and answer the entirely wrong question. By treating places and the lived experience and impacts of residential segregation as nuisance factors to be quote unquote corrected for by weighting, the CDC reached the entirely wrong conclusion. Partly because of the criticisms raised this past summer, one briefly could find a single table that included results based on both the weighted and unweighted population data, along with the total population racial ethnic composition. But since early fall, the CDC has reverted to showing simply proportions based on counts of cases with no data on population composition, hence no way to gauge under versus overrepresentation compared to total population. The same problem affects what's going on now with the vaccination data being presented. However, as the unfunded work of our team and so many other colleagues dedicated have demonstrated, from the very start, it was and remains feasible to document COVID-19 inequities here and now. The 4 examples I will present involve county level zip code and city town metrics of inequities, 2nd, occupational complaint data from OSHA, and 3rd, mortality data jointly by race, ethnicity, and education. So here are the data we were the first to produce in early April on COVID-19 death rates for all US counties in relation to key social metrics, drawing on our longstanding work with the US Public Health Disparities Geocoding Project, which I have led since the 1990s and whose methods and materials are freely available at our website. As you can see, the highest death rates for COVID-19 occurred in counties with the highest poverty rates, highest crowded housing, and highest proportion of populations of color. However, for the measure of racialized economic segregation, which I developed building on Massey's index of concentration at the extremes, a U-shaped curve is apparent, reflecting how the pandemic initially struck those affluent enough to be international travelers and then became entrenched in communities replete with low-income essential workers and crowded housing. These are systemic problems structured by social injustice. I also want to emphasize that the measures that we use are not simply quote unquote proxies or so-called ecologic variables that are stand-ins for individual characteristics. Instead, they are contextual measures telling you precisely about the context and the communities hit hardest by COVID-19. Building on this study, we turn to the inequities in the mortality surge tied to the pandemic, and in early May reported the first US data on this surge in relation to social metrics. For the study, we compared the total mortality rate, that is the number of deaths per 100,000 person per 2-week period, to the mortality rate for the same 2-week period based on the average for the past 5 years, 2015 to 2019. The value of this approach is that it captures all of the excess deaths, both those categorized as COVID-19 and those that should have been attributed to COVID-19 but were misclassified, for example, due to lack of COVID-19 testing. And it also captures deaths that are due to the pandemic but not the infection, for example, due to delays in getting needed non-COVID healthcare, and also takes into account the background seasonal fluctuation in causes of death. Using this approach, we computed the excess deaths for every city, town, and zip code in Massachusetts, characterized again in relation to their social and economic composition. To illustrate on this slide, I show 2 of our updated analyses from our article published in mid-October for 2 of the 4 variables: the index of concentration of extremes for racialized economic segregation, whereby a value of -1 means 100% of the households are low income and of color, and a value of 1 means 100% are high income and white non-Hispanic. And then secondly, also percent crowded households. The data for 2015 to 19 are adjacent to the 2020 data. The lines show the groups ranging from low to high for each variable. And no matter the measure that we used, all 4 social metrics show the same terrible facts, albeit most acutely for the measure for racialized economic segregation. The death rate surged much higher among communities that bear the brunt of racial, ethnic, and economic injustice. While these patterns may not be surprising, our study was the first to document them and provided critical evidence necessary to inform COVID-19 policies. Moreover, our study, which we conducted in collaboration with our newspaper, the Boston Globe, enabled the reporters to do important investigative reporting on some hard-hit communities that our research identified, but which had not yet received public coverage of their hardship. This reporting helped galvanize public health and public awareness in these communities, putting their experiences and needs in context. Underscoring the patterns we identified, new research is showing that workplaces are key sites of infection, and also that household crowding, not population density, further drives community spread. And regarding work, here are results from our study last fall, the first to analyze workplace OSHA complaint data in relation to US COVID-19 mortality rates. The context was a federal administration that refused to establish any COVID-19 workplace standards, reduced workplace inspections, and reported virtually no data on COVID by occupation. We revealed that rises in workers' COVID-19 complaints shown by the vertical bars, with blue for workers in healthcare and other social assistance occupations, purple for retail workers, orange for workers in manufacturing, and tan for the rest, resemble an epidemic curve, with the mortality rate shown by the black line following in kind. The bottom half shows the heat map that we made of correlations between the complaints and mortality rates, and demonstrate that the strongest correlations occurred for deaths 16 days after the complaints, with an R equal to 0.83. The power of this finding is that we demonstrate the temporal order. It was not as if workers became aware of rising death rates and started complaining at work. Instead, workers complained first and the deaths followed, with an unsurprising lag of a little over 2 weeks, given incubation period and time to manifestation of lethal symptoms. Data on occupational inequities in COVID-19 remains scarce, scant at government websites, yet new academic studies are now finally documenting essential workers' increased risk of COVID-19 mortality. The larger point is that ignoring or suppressing these data does not make the problems go away. It just makes it harder for those organizing for health justice to press their case for better prevention and protection, both in the courts of law and the court of public opinion. But things are changing, and post-January 2021, under the new administration, new data are cropping up at the CDC website. Our latest analyses show the harm caused by reporting only racialized rates without attention to the profound links between racialized and economic injustice. The top row shows the COVID-19 mortality rates per 100,000 persons years for January 1, 2020 through January 31, 2021. Clearly, both racialized and educational inequities exist, with the gradient for the latter especially steep. Moreover, because CDC has finally released data that allow one to stratify jointly by racialized group and education, which is not exactly a novel concept, it becomes possible to document, first, that strong educational gradients occur in all racialized groups. Second, setting white non-Hispanic persons with a postgraduate degree as the referent with a rate of 80. Rate ratios are over 3 times higher for Black, Indigenous, and white non-Hispanic persons with at most a high school degree, whose rates are on the order of 350 to 425, and they are 8 times higher for Indigenous persons with less than high school, with their rates reaching 625. Note, however, that education has been a standard variable on the death certificate since 1989. It is not as if these are obscure data. Occupational data are also standard on the death certificate and can and should be analyzed for working age adults. Once again, the two-edged sword of data cuts deep. The absence of linked racialized and economic data is a denial of health justice. So in conclusion, we need better data to inform action. Data should reveal racialized economic health inequities in real time, and all COVID-19 data should always be presented jointly by racialized and economic group, along with age and gender. My specific recommendations are as follows. First, immediately, 1, use informative contextual zip code data with all COVID-19 outcomes. True, I prefer data at the census tract, but in an urgent pandemic, zip code is fine. Second, use individual level education and occupation data where available, especially for mortality data. Third, capture real-time economic shocks by using the real-time US Census Household Pulse Survey, which is available for all US states and the 15 largest metropolitan statistical areas. And fourth, create a real-time public roster of the new social data that CDC is now adding for COVID-19 under this new administration, so that data users can quickly access these data rather than scramble and spend valuable time trying to find out what's new and go down various internet rabbit holes. Looking at the bigger picture, structural problems always require structural solutions. It's not an accident that the same data problems keep propping up and persist, and this gets back to who wields the two-edged sword of data to what end. My 3 concrete suggestions are: first, for COVID-19, ensure that data reveal problems tied to work conditions, crowded housing, lack of sick leave, lack of healthcare, and congregate living, including for incarcerated persons. Second, mandate that all racialized data must be reported always with contextualized social metrics and mandate the funds and for the necessary resources, which means both people and technology, to do the work. Unfunded mandates never get done. And third, expand data governance to ensure real representation of those whose lived experience of inequities are being documented so that this is done fairly and shows structural causes. Thank you, and I look forward to your questions. I'm honored to be here.
Thank you so much, Dr. Krieger. If you stop sharing, thank you. It'll be wonderful. While people think of their questions, I might take Chair's prerogative and get us started. You gave us a lot to consider in that presentation. And in particular, I wanted to revisit the contextualized social metric. I think, metrics, be clear. I think so often we have this challenge or perhaps the conversation goes to incompleteness of data, inability to collect the data necessary, feasibility of execution and large scale. Might you speak for a moment to what you think in terms of quality, completeness? You spoke a little bit to availability in some of this, but as we perhaps consider implementation pathways, where should we be in that part of the conversation?
So there's two parts to this, and thank you very much for this question. One is, what are the incomplete individual level data? And it makes no sense that there should be so much data missing on race ethnicity. And there may be some states that have reasons that they're not reporting the data, but generally it seems that it makes no sense given how many other health conditions and outcomes there are for which there are always racial ethnic data. So why COVID is sticking out as missing so much of these data is really mysterious and needs to be addressed. So that's a really key part. The second part is that it is increasingly easy to be able to link to contextual metrics. There are a lot of websites, CDC has websites up also, and there are indices that people use, but I think that what's important is that they're also easy to construct, and we make available our measures of racialized economic segregation at the census tract, zip code, and county levels. So data can be linked very quickly. If you know zip code, you can go to almost all of these other levels very quickly. It's easy to do. The programs are there, they're available. So there's no reason not to do that. And that matters in terms of saying it's about both place and also the characteristics of place, because the geographic parts of place, I've heard several of you say you're concerned about issues of transportation or what it is to be rural. Where you are located, it's not the same, you have to take that into account. And there are many easy statistical ways that you can address this in your models. So I think that the linkage and making sure that there are those data that are available through linkage to contextual measures, because it's true that in many health surveys and many of the vital statistics, you're not going to get income data very easily. That's not going to happen. You're going to get that from the contextual measures. You could potentially much more easily get things like education. And one thing to think about education as a variable is that it's never going to capture the economic shock per se. That's where the income data become important, and why also cross-linking across different data sets within government, taking advantage of the extraordinary work that the census has been doing with the household pulse survey is really critical to bring together the different pieces. So I think the other part is not to think that the answers for this lie only within the health data, but I was very glad to hear you talk about the other agencies that you're bringing on board. What other data does HUD have, for example? What other data do the education department have that can be linked with the health data? And if this COVID-19 pandemic can get people to be taking more seriously the needs not only to link the data, but the resources to do that. I know from colleagues working in lots of health departments, local and state, they do not have the resources to do that. They need outside academics to help figure things out to try to make the programming easier and to do, but so there's implementation. So it's not just the technology itself, it's the people power to do that and the funding to do that. And that's also key to understanding data gaps.
Incredibly helpful. Thank you, Dr. Krieger, for those insights. Mr. Imperato.
Thank you, Madam Chair. Dr. Krieger, thank you for acknowledging early in your talk about the scarcity of data related to disability status in the context of COVID. That scarcity is really being used against us in many states as we try to have priority for vaccines, because the states are telling the disability community, we don't have good enough data to know that people with disabilities are at higher risk of dying from COVID, so we're not going to prioritize you for vaccines. And I'm just wondering if you have thoughts about anything we can do in the short run to address that data challenge.
Do you have data from other surveys on disability that are geographically referenced, whereby you can look at what the rates are of the different kinds of disability and then correlate them with what's going on with COVID? In some ways, that's similar to what we were doing with the occupational complaints, for example. So the OSHA complaints are one whole set of data, and then looking at the correlations with the COVID data is a way to start to make some suggestions about where might there be excess burden.
That's great. I think the short answer to your question is yes, we do have data from other sources. So we'll look into that, but unfortunately, we're not getting a lot of help from the CDC right now. So part of it for us is trying to get better federal leadership to help us identify and analyze the data.
One thing I would just quickly add is, there's an enormous research. I can promise you, there are a ton of public health students who want to help and bring their skills to bear. And if there is some way that this task force can help direct students and say, here are projects, go for it with oversight, that's a real resource in this country.
Yes, love our students. Thank you, Dr. Krieger. Dr. Putnam.
Dr. Krieger, thank you very much for that education and for your passion that you bring to this. I appreciate what you've done, especially when it comes to zip code data and being able to find out exactly what's going on. With the rise of the potential new variants coming in, the frontline healthcare staff is particularly concerned about who's going to get hit hard, when, how fast it's coming. So I was intrigued by your comments about real-time data. How do you anticipate, because the data lag has been pretty substantial throughout this pandemic. What are the sources for real-time data, and how do you recommend getting that data to be accurate so we know and can prepare for something much more quickly than we have?
So I think the question partly is which outcomes you're looking at. If you're concerned about variants, I heard on the webinar that was just sponsored by the American Public Health Association and the National Association of Medicine, Dr. Walensky talking about increasing capacity around the genomic surveillance to try to look at what's going on with evolution of variants of the virus. And I have colleagues that work on that. And there's a question if you're trying to keep track of what's happening with the virus and what the potentials are, particularly with real-time faster monitoring with sewage, for example. There's a whole sort of line of work that's doing that, which is very separate from testing people. So I think it's a question of what you're asking. If you're asking about the case data and the mortality data, that's always going to involve the recording of forms for people and the processing of those forms, and that's a little bit different.
I guess specifically my question on real time is, learning that we were hit hard 3 weeks ago doesn't help the folks on the front line. Is there any way to move that a little bit farther forward, or can we get to real-time data, what's hitting or what can be expected to hit a particular region or group?
There are colleagues of mine that work more from a data science perspective that are trying to look at what data can be analyzed from what people are searching on the web. Those have not necessarily been shown to be as robust as you might like for really understanding what's going on. So I think that it's more that it's looking at the shape of the curves itself to get a sense of what the trajectory is. And then this new uncertainty about new variants is part of the struggle of a real-time pandemic. That's a new thing. So I think you would need to speak with colleagues that have that kind of expertise, which I don't. And one thing that's very important to me is not to speak beyond my expertise, to say what you could best do to get real-time data on whether there are new variants showing up and what the implications are.
All right. Thank you very much for your work. I appreciate it.
Absolutely. Wonderful. Let me just add thanks again. As I look around, Dr. Krieger, you gave us a lot to ponder and consider as we launch on this work. We will be talking with you further. Thank you so much for your time today, for all that you're doing to advance the work in data and in COVID-19 health justice and beyond. Much appreciated.
Thank you.
We'll turn now to our next guest, Mr. Daniel Dawes, and thank you as well for joining. Let me provide us with a brief bio. So Mr. Dawes is the Executive Director at the Satcher Health Leadership Institute. based at Morehouse. He's a widely respected lawyer, author, scholar, educator, and leader in health equity, health reform, and mental health movements. He is a professor of health law, policy, and management. He's also the co-founder of the Health Equity Leadership and Exchange Network, or HELEN, which is a nationwide network of over 2,000 governmental and non-governmental leaders and scholars focused on bolstering leadership and the exchange of research, information, and solutions to advance evidence-based health equity-focused policies and programs. Mr. Dawes' own research focuses on the drivers of health inequities among under-resourced, vulnerable, and marginalized communities, and is the pioneer of a new approach to examining equities, the political determinants of health. He brings a forward-thinking, inclusive, and multidisciplinary approach to health policy, authoring 2 groundbreaking books, 150 Years of Obamacare and The Political Determinants of Health, published by the Johns Hopkins University Press. Dawes is an elected fellow of the New York Academy of Medicine and served on several boards, commissions, and councils focused on improving health outcomes and elevating health equity in the US and around the world. And he too is the recipient of several national awards and recognition. So without further ado, Mr. Dawes, thank you again for joining us today, and the floor is yours.
All right, well, good afternoon, everyone, and thank you so much, Dr. Nunez-Smith, for that very kind introduction, very generous introduction, and also for the invitation to highlight some of the data challenges and opportunities impacting our ability to realize health equity in the United States. I just want to quickly also thank your team members, your team members, Dr. Cameron Webb and Ms. Sharice Perry, and the esteemed members of this task force for your unwavering commitment to ensuring an equitable response during this pandemic and beyond. Why is that so important? It's because since 1793, when yellow fever struck the United States, all the way until today, we've never been able to realize an equitable response during a pandemic or epidemic. And it's always the same groups of individuals that are on the downside of advantage and opportunity who are most negatively impacted. Racial and ethnic minorities, lower socioeconomic status individuals, people with disabilities, and immigrant communities the worst. It's a real honor, again, to follow on the heels of Dr. Krieger and provide some additional insights on these critical issues. So our mission at the Satcher Health Leadership Institute is to create systemic change that will lead to a healthier, equitable, and inclusive society. And it is through that lens that my remarks are framed and was developed through a collaborative process with colleagues who represent the interests of diverse population groups, including people of color, people with disabilities, LGBTQ+ individuals, older adults, rural and frontier populations, and people living within the United States territories. So we've heard Dr. Krieger talk about structural racism, and I wanted to bring up this great quote that was published in Biostatistics, where it says, structural racism is a critical body of knowledge needed for generalizability in almost all domains of health research. In this article, the authors point out that structural racism refers to the totality of ways in which societies foster racial discrimination via mutually reinforcing inequitable systems, such as housing, as we've heard, education, employment, yes, even healthcare. And in turn, these reinforce discriminatory beliefs, values, and distribution of resources. And it's that last part that really resonates with me, given the global pandemic that we're all currently living through, the distribution of resources. The differences in resources that one group of people gets versus another can make all the difference in terms of life or death, which is why I urge you to support the collection of complete race and ethnicity, as well as social and political determinants of health data. As Dr. Lauren Smith reminded me this morning, we in the public health arena haven't explained well why we need racial and ethnic data, even as we argue that race is a social, not biological construct. It is a broader issue than just the effort to get the data for testing results or vaccination. I think we can say that it is a social construct, and we need to collect it precisely because we know that experiences, opportunities, and threats are stratified by this construct. And we want to be able to hold ourselves accountable for ensuring equitable responses and outcomes moving forward. I think there has been some confusion as to why we would need that data if it is not a biological phenomenon. We must focus on pushing that argument. So let's talk about this dark and historical moment that we're in, right? We know that this is a historical moment that we're living through. But when you begin to really look at the numbers, at least from the limited data we've been able to glean, it becomes clear that this is also a very dark moment in history. When I put these slides together, earlier this week, we were 502,000 COVID deaths and climbing, as Dr. Nunes-Smith mentioned, right? Well, that only begins to scratch the surface of the disproportionate carnage that this virus is inflicting on the most marginalized in our country. I could go on and on about these statistics, right? But it's truly sad. In the first 6 months of 2020, what we all expected actually occurred. That US life expectancy dropped by a full year. But for Latinx individuals, it dropped by nearly 2 years. And for Black individuals, it dropped by almost 3 years. American Indian and Alaska Native persons are facing a mortality rate that is almost 2 times higher than non-Hispanic whites. And even in our children, of the precious young lives that we've lost, 75% have been people of color. So I could go on, but I probably couldn't, because eventually I run into a wall of available data that highlights these problems. Sadly, the old adage of if there is no data, then there is no problem, right? Apparently remains true in 2021. But one thing we do know is that it does not matter which region of the country you look at, vulnerable communities everywhere are being harmed. East Coast, West Coast, the South, even outside of the contiguous 48 states with our territories, the US Virgin Islands, Puerto Rico, Guam, our most vulnerable are shouldering the burden of this pandemic. The problem within the problem is that I was able to just very quickly highlight the grim reality of this moment in history. And I did so by providing you with alarming statistics. But we have to have the data in order to do that. And that is neither a simple task nor even feasible in many instances. Yes, there is no denying that we are in the midst of a dark moment in history. But at the Satcher Health Leadership Institute, we strongly believe that collaboration can and will serve as a guiding light to a better tomorrow. In the spirit of such, with partners such as the CDC Foundation, Google, Gilead Sciences, and the Annie E. Casey Foundation, we convened a brain trust to help us chart a path forward by bringing together a diverse group of leaders who represent some of our most marginalized communities. We've begun to be able to formulate actionable solutions, and I want to share that with you quickly today. So one of those solutions is the creation of a health equity tracker. Slated to go live in April of this year during Minority Health Month, the Health Equity Tracker is intended to be the most comprehensive health equity tracker in the United States today. You see, we as a country have experienced pandemics and crises before in our history. And due to the innate resilience of the American people, we have always weathered these storms and emerged stronger on the other side. However, what is interesting is that we've never, like I said, achieved an equitable response to a pandemic specifically. And I believe this is our opportunity to do so. And with your leadership on this task force, I believe we'll be able to actually realize that. But to actually achieve an equitable response, we have to know that inequities exist and persist across the country. While there are a number of trackers out there right now that are looking at COVID data specifically, and I might add doing so very well, the tracker that we've designed takes a more expansive look at health equity specifically to truly inform people of the problem and attempt to fill in those data gaps that Dr. Krieger mentioned earlier, right, that have long plagued us. Our health equity tracker will be a public-facing data platform, usable by any and all, quite frankly, that exists to help folks understand the health equity impact of COVID-19 and other comorbidities striking vulnerable populations, including mental and behavioral health issues. We will also examine and incorporate social and political determinants of health to overlay on that data so we get a richer picture of what's really going on and connect the dots so we can respond both in real time and accordingly. What is most important is that our tracker will live beyond this COVID pandemic. and continue to facilitate the conversation around health inequities and the data highlighting such. Well, while the tracker is intended to be bigger than the current moment, we knew in early 2020, and we still know in 2021, that people need help, and they need help now. To that end, we recently launched our National COVID-19 Resiliency Network that exists to link vulnerable communities with the resources they need to survive and thrive. The work of our Resiliency Network, or NCRN as we call it for short, was brought about by a $40 million grant from the Office of Minority Health at HHS. And it has allowed us to begin the process of accessing some of the hardest to reach and often overlooked segments of our population. With that added exposure, however, comes increased data challenges and more chances to conceive of data opportunities. So let's talk about these challenges briefly. From our Health Equity Task Force to our Health Equity Tracker to our NCRN, we have begun doing the actual work necessary to help the communities we aim to serve. But in doing so, the challenges in the data that we've been working with have become so readily apparent that it is virtually impossible to ignore. Being able to see firsthand where the data gaps reside, and more frustratingly, being stopped in real time by data challenges has made the actual work that we've engaged in that much more difficult. And during a time when it should be all hands on deck, working together to tirelessly overcome this pandemic and protect everyone, running into challenges around racial and ethnic, disability, and other important data simply is unacceptable. Well, when it comes to minorities, there are gaps in the available data. Surprise, one of the most persistent challenges that we have encountered has been in regard to a lack of standardization. Right now, the most up-to-date data for COVID cases, hospitalizations, deaths, and vaccines are scattered across state and local public health websites that use different standards and categories for reporting race and ethnicity. This is a problem that many of the COVID trackers encountered and tried to address with volunteer human power, and is the reason why our Health Equity Tracker leans so heavily on technology to automate as much of the data collation and aggregation as possible. Beyond this, though, we've seen that many agencies do not reliably collect race and ethnicity data, while some of the others that do collect it fail to report it, which means that the data is not getting into the hands of those of us who so desperately need it to tell the stories and fight for our communities. Even when we look towards the gold standard of data collection, the CDC, some of these data sets fall short, as we heard earlier. Take, for example, the CDC's restricted data set that we were able to get, right, and granted permission to access back in December of last year. This data set has additional fields to help paint a fuller picture. Yet, these additional fields that include whether the person died or was hospitalized are only known for fewer than 40% of cases. And even still, when you move beyond the COVID-specific data, there is the glaring and undeniable reality that there is simply an inadequate amount of data that analyzes and highlights the upstream factors that perpetuate many of the isms of our society. Being able to quantify the social and political determinants of health and their impact on health outcomes would work wonders for telling the story of health disparities and inequities in our country. And that's precisely why we are currently building out a legal epidemiology data set with our partners that will be incorporated into our Health Equity Tracker to analyze variables such as the presence of and the impact of stay-at-home orders, or the healthcare infrastructure of given regions, or the disparity and significance of insurance coverage, just to name a few. Yet, even detailing these data hurdles does not encapsulate the breadth and the scope of the challenges that present themselves when you begin digging into the intersection, as Andy Imperato mentioned, between race, health, disability, and data. Well, I'd be remiss if I did not point out very quickly the growing concern that algorithms may reproduce in terms of racial and gender disparities via the people building them, or even through the data used to train them. And empirical work is increasingly lending support to these concerns. According to a recent study that was published in Science, an algorithm commonly used by hospitals and other health systems to predict which patients are most likely to need follow-up care, right? Classified white patients overall as being more ill than Black patients, even when they were just as sick. The reality is that many of these race-adjusted algorithms guide decisions in ways that may direct more attention and resources to white patients than to members of racial and ethnic minorities. I bring this up to highlight a couple things, but one specifically, that the challenge to get quality racial and ethnic data goes beyond COVID and is such an entrenched problem that it is at times baked directly into our healthcare decisions. Well, let me quickly segue into our recommendations and close out. You know, as I said before, this certainly is a dark time. And so I'm not here to simply tell you about the challenges we've encountered in the midst of our COVID work, but also to offer up some practical solutions and recommendations to the task force. So first and foremost, I earnestly believe, along with my colleague, Dr. Brian Castrucci of the de Beaumont Foundation and others helping us to build our health equity tracker, that the federal government should invest in the deployment, financing, and maintenance of a national public health data infrastructure to collect and report data out in real time, as Tom Putnam mentioned earlier. Because right now, it's like we are flying a plane with 50 different instrument panels, as Brian puts it. So is it any wonder why we've encountered the many problems around data during this crisis? Well, not really. The CDC has the capability to address many of these challenges. But in order to do so, I think that the CDC should be provided the resources to assemble and publish comprehensive COVID outcomes and vaccine data. This could come in the form of examining policy or regulatory options to compel the collection and reporting of racial and ethnic data by local agencies. For example, simply implementing OMB Directive 15 at all levels of data collection and analysis and presentation would be a huge step forward, as that alone would remove one of the most damaging forms of structural and institutional racism and could completely transform how COVID-19 data is visualized. Another great example would be to take extra care to collect data on disability status. The CDC could fairly use the American Community Survey, which is a set of 6 disability questions, as a model to establish a minimum requirement across all federally conducted data sources, to Andy's point earlier. And we need a registry in primary care practices to identify and track COVID patients with detailed demographic, social, and medical history. Public health has no access to these data sources, as you may know. Being able to analyze how this virus and its lingering effects impact different groups of people and their varying experience and prognosis would be invaluable. We also need to be able to understand our successes and failures in the vaccination effort, knowing who is doing well in reaching disproportionately impacted communities so that we can build the appropriate infrastructure and have adequate investment next time around, which I think could save 500,000 lives according to research. To this end, all too often, the infrastructure and places that already support health equity initiatives are underutilized. I'm referring to our federally qualified health centers, rural and independent pharmacies, and many primary care practices. If the reporting of other quality measures and metrics in healthcare were to include requirements for granular race and ethnicity data and other identifying information, then I think we could more equitably respond to public health emergencies and evaluate the equity impact of a public health crisis and response. Other identifying information and variables that relate to the social determinants of health would also be illuminating. Variables such as economic and social consequences, as we heard Dr. Krieger mention, of COVID or other viruses could inform us about racial and ethnic specific conditions that impact the spread. Further, if the data infrastructure had been in place before the pandemic, we most likely would not be in the present situation of attempting to coordinate a pandemic response while simultaneously understanding the unfolding and compounded inequities of the pandemic with poor quality data. It almost goes without saying that In order to support such an infrastructure, there needs to be national standardization of categories of race and ethnicity, gender identity, sexual orientation, disability status, and many others, so that the systems can be built to collect this data, and the data can be merged and used across platforms. Let me close by saying that I do want to take a moment to push back on a common refrain that we've heard and read as of late, and that is the desire to return to normalcy. I do not know how else to state this, but to be blunt about it, there absolutely cannot be any return to normalcy. Normalcy failed us before, and it will fail us again if we don't act now. Normalcy before COVID left marginalized communities without the resources they needed to survive and without the data to tell their stories. It meant widening racial gaps in income and wealth, higher rates of food insecurity among Black and Latinx households, and less than half of low-wage workers with access to paid sick leave. Normalcy during COVID has left those same communities literally scrambling for their lives and still without the data to highlight their plight. When we emerge on the other side of this pandemic, and prayerfully, that is much sooner than later, we absolutely cannot ignore the tough lessons we have learned by attempting to return to a pre-COVID mindset. The data landscape before COVID was just as dire as it currently is, which means we have an opportunity to act right now. Normalcy is not equity, and equity should be our only option moving forward. I want to thank you all for listening and for the privilege of your time. Thank you again, Dr. Nunes-Smith.
Thank you so much, Mr. Dawes. Just another exceptional presentation. We do have time for some Q&A. Thank you. I will turn it to Dr. Calhoun and then Mr. Toronzo, please.
Thank you. Thank you so much, Mr. Dawes, for your presentation. I've heard several of your presentations over the past several years, and they're always very informative and innovative, and you're so inspiring. I have a question about the health equity tracker and what your sources of data will be for that.
Oh, thank you so much, Dr. Calhoun. And let me just say, in terms of the sources, as you heard me, it's been very difficult, right? But we are going to be collecting data. They're public sources of data, so CDC data as well as other data sources. And then we're also working with private partners. So we are trying to get access to health insurance data from our insurance partners. We're trying to get provider level data from key partners that represent hospital systems, as well as FQHC data. We are also working with another company to get the testing data so that we can also see who has been able to get tested versus those who haven't, and understand the trend throughout this pandemic and paint that picture. So Castlight is one of those partners, along with Gilead Sciences with remdesivir and the like. But we welcome additional sources of data.
Wonderful, thank you. Mr. Toronzo, please.
Thank you, Madam Chair. First of all, I'd like to thank Dr. Krieger and Mr. Dawes for presenting their findings to the task force today. Mr. Dawes, you mentioned in your presentation, I have two questions, but you mentioned that amongst children, 75% of COVID-19 deaths have been children of color. And you mentioned further in that 45% were Hispanic and 29% were Black. As it has been reported, the CDC has said that the spread of COVID-19 is incredibly low when we're reopening schools. So I guess my question to you would be, do you suspect that this number of deaths amongst children of color would increase if we take into account the new variants?
Wow, that's a really difficult one, right? So let me just say that from my experience early on, and I think Dr. Krieger was talking about this, we actually had to create a coalition that would enable us to get access to the data, at least some disaggregated data by race and ethnicity, right? So we know that we're not getting the full picture. We got a snapshot of some of that data early on, and we've been pushing and trying to get more. So I'm not sure how to answer your question. I have no idea. I think it's going to be circumstantial, right, by from individual districts and school superintendents and how they tackle this. And I think it's going to be dependent on the resources that these schools are given to protect themselves, right? We know early on, I think Dr. King was one who mentioned this from the Educational Defense Fund, when we talked about the dearth of protective equipment in these communities, right? And in talking with school districts across the United States, I know you're in South Florida, so Broward schools, Miami-Dade County and others, we know that they early on were having trouble getting those resources. Now, do they have that today? That is beyond my level of expertise. I don't really focus on the education piece, but I do have colleagues who do that. So I'd be happy to get to you and give you a more informed answer.
Thank you, Mr. Dawes. And my second question would be, you mentioned that only one state has vaccinated at least 10% of its Black population. Do you know what state that is?
Absolutely, that was New Mexico.
Okay, thank you, sir. Appreciate it.
Sure, absolutely.
Thank you so much. So Dr. Martinez, and then we'll have Ms. Turner and Ms. Alvarez.
Thank you, Madam Chair. Daniel, wanted you to weigh in on what are your thoughts? Love the point about standardization of data. I think that is a very key one, especially definitions. As an example, rurality there's no consensus on how to define just rural counties at the federal level and also at the state level. So that can cause some issues. But the other area that I haven't heard a lot of, and especially when it comes to the data, is the excess deaths that are happening due to COVID-19. So we're hopefully capturing those that we can directly attribute to COVID-19, but it is having this huge, mental health and emotional impact on our population, where folks are not going to the hospital, they're not going and seeing their doctors. And there's a lot of individuals with chronic illnesses that are probably not getting the care that they need. As an example, maybe someone's passed away from a heart attack, but should they have prior to the pandemic? And where I'm getting to this is knowing the demographics and also the risk factors for a lot of our communities of color. Are we capturing that data as well? Because I have a sense, but I can't at this point to any data set that tells me overwhelmingly it might be actually or disproportionately impacting communities of color. And a related one is, should we have guidelines to our medical examiners when it comes to the causes of death and taking into consideration the overall impact that COVID-19 is having? I know that's a bit packed, but I'll see what you can tell us about this.
So, and I appreciate that, Dr. Martinez. You always come up with some great questions. Let me just say, there's two sides to that too, right? We've heard folks who have said you are overcounting in other countries excess deaths. And in the United States, we've heard folks saying we're undercounting it. I tend to lean and believe that we are undercounting it based on our experiences throughout the pandemic. And so I would probably agree with you on that. In terms of the other piece, what was the second part of your question?
Oh, the second part was it comes to the standardization of data, but it's also the guidelines we need to be giving, for example, our medical examiners out in the field.
Yeah, absolutely. So, early on when we were, and I know Myra Alvarez remembers this very clearly as well, as we were developing the Affordable Care Act, and we all know that there's 62 provisions in that law that are addressed and intended to elevate health equity. One of those, though, was data collection and reporting, right? Of all of the priorities for health equity leaders during the ACA negotiations, data collection and reporting was key. Well, we know it didn't go as far as we'd like, but there are still provisions in there that had authorized HHS to go in and to think about strategically how we can standardize additional data, right? So LGBTQ communities, people with disabilities and the like, and it was taking off, but then things stopped in 2017. I think there is another opportunity, because it is authorized by law, for us to really continue that great work and develop additional standards where we were close to doing so on these other data sets that you're talking about. So I would say there is legal authority to do that, and that's another lower hanging fruit that we can take advantage of.
Thank you. Ms. Turner, please.
Yeah, Dr. Dawes, thank you for your presentation. My question is about how or if the health equity tracker collects data on barriers to access to care. Attempts to make COVID treatment free has been lackluster. And with high co-payments and deductibles and out-of-pocket expenses, our most vulnerable patients are often forced to forego care due to unaffordable costs. Similarly, how do we collect data that helps us to understand the impact of hospital closures and trauma deserts that are concentrated in racialized communities?
So, Dr. Turner, thank you for that great question.
Nurse, you just elevated me.
All right. Well, Nurse Turner, thank you so much. And thank you for your leadership during this pandemic. So I just add that, yes, you're absolutely right. That is a key component of what we are trying to achieve with the health equity tracker. You know, we initially set out to track the inequities relative to COVID, right? And of course, looking at from a public health standpoint, but also a healthcare access issue, right? We want to be able to track health insurance coverage. How has that been a barrier to accessing health services in this country? That has been problematic to date to get that data, right? We want to be able to understand, you know, the provider network, so the hospitals and the clinics, and we're mapping those out, and the primary care practices. And what we want to do is to create essentially a green book for vulnerable and marginalized communities, looking at providers who have taken equity to heart, that are truly trying their very best to ensure that they can provide accessible or equitable access to health services, to COVID testing, right? So we're mapping out the testing sites. We want to see early on, again, where are those inequities, right? Or do they still exist? Have we learned lessons from that as we are now venturing into the vaccination period or phase, right? So those are all pieces that we are trying to incorporate in addition to these social determinants of health factors, like looking at housing density, looking at the multi-generational housing in these communities and the impact that that might have, right, on health status and health outcomes during this time. So there are multiple pieces to this. We're trying to look early on too at the impact, going back to Dr. Martinez's point, right, about how a lot of folks are fearful about even venturing out to go and get, you know, services, healthcare services for their diabetes, right, or for their asthma and for other chronic diseases, or for mental health services and substance use services, right? And what is that impact really looking like as we move forward? We know it's having an impact on the life expectancy as a measure of health. But I suspect it's even worse when you look at these vulnerable groups. So we are trying to map out, and I welcome the task force's help, your help and others, in helping us think through what other factors should we be thinking about and collecting.
Thank you. All right, I think we do have time to hear from Ms. Alvarez and then Mr. Joseph, please.
I want to go back to something. Actually, let me first say thank you, Dr. Krieger, for that incredible presentation. Just the quantity of data, the points that you made about where we have to ensure we're getting quality data from and focusing our efforts on. Obviously, you are a champion, and it doesn't even cover it for this work. And it's just an honor to hear you present and be part of this conversation with you. And Mr. Dawes, it's just great to reconnect with you, and thank you for your presentation. My question to you actually also dovetails off of our chair's opening comments, which really talked about the mental health implications of the pandemic and the many ways in which the pandemic is impacting the lives of every community across the country, but frankly, disproportionately people of color. And I want to talk a bit about grief and the loss of kids being able to play with their fellow students or be in the classroom, the loss of social interaction with our families and what that does to our mental health. And then frankly, the loss of lives and what that means for the people that are grieving their loved ones and cannot even grieve in the way they want to because of the limitations of the pandemic and what it's placed on us as far as safety is concerned. You mentioned that in this tracker, there'd be opportunities to cross-populate data related to mental health in order to better understand how the pandemic and its disproportionate impact on certain communities correlates with mental health instances. Can you talk a little bit more about that, given the challenges that there is on data collection for mental health illnesses for communities of color, but communities more broadly?
Absolutely. And thank you for raising that issue. So, you know, we know that mental health, behavioral health has been underrated, right? You know, as a health policy issue, and even more so when we talk about the data. And to your point, we know by, you know, looking at recent studies that 1 in 3 African Americans, for instance, know somebody who has passed away from COVID, right? And a similar result for Hispanics and others. And so what we thought about early on was that we recognize that mental health is critical, is just as important to our systemic health as these other factors, right? And so we are committed to tracking 5 variables. We will look at anxiety, depression, suicidality, addiction, and Alzheimer's. And we are going to try our best to get our hands on that data and look at it throughout the life course, right? From children all the way to older adults. We want to be able to track those and to understand either by age or geographic region, do we see certain trends? And to, I believe it was Mr. Putnam's comments earlier, we want to be able to do that in as close to real time as possible, right? Because it doesn't make any sense to get this data when it is a year old or 2 years old. We need it as close to real time so we can create those actionable solutions, the interventions, the supports and services that are needed for these communities and for these individuals that are suffering. So thank you for that. That is where we are right now, and that's what we're looking at in terms of the 5 variables. We'd love to expand upon that as we move forward, but we think those 5 are more doable for now.
Mr. Joseph, please.
Thank you, Chairman. I really appreciated Dr. Krieger's and Mr. Dawes' presentation, and it gave a lot of information. Both of you indicated the disparity with American Indian and Alaska Native and to other races and how much higher it is. With that, you both made some really good points that I want to mention before I get into my direct questions. Ms. Krieger, you talked about in one of your last slides, you need to have better data to inform action. Mr. Dawes, you just said it right now. You need real-time data to make those decisions. The challenges that the tribes or tribal medical providers or health organizations are having is the access to that real information to help drive their action. So one of my questions to you when we're looking at that specifically is, what challenges were you having when you were trying to specifically look at American Indian and Alaska Native data elements?
Yeah,
you also pointed a little bit more. Also, too, Mr. Dawes, you talked about a little bit specifically on health infrastructure and the need for that health infrastructure. I would like you to expand a little bit more on that. There's so much to be said there, and it's such a big topic item that I think it's going to be really important for us to fully understand. As we look at gaps in available data, and I think that's where my first question comes in lines, because there's a lot of gaps, but how are those gaps being pointed out in collaboration with not only CDC, but with states and how they may be impacted tribal communities? And so I wanted to just throw that out there. If you have any questions about what I just stated, I'd be more than happy to clarify, but those are some really important matters to address.
Yeah. All right. Well, thank you, sir. I appreciate those questions. And let me let me tackle your first one, which is challenges with collecting data during this time period with Native American communities. And I will say that you know, as part of our efforts, we included the Indian Health Service into our work. Michael Todt from IHS to understand what data points were accessible at the IHS so we could understand this. We also brought in folks from CDC who are working with various tribal nations through their epidemiology work. And then we've also brought folks that can help us at the grassroots level in various nations. So we're starting out first with the Navajo Nation, right? To understand what challenges do they have. That's coming through the pipe for us in our national COVID-19 resiliency network. And so you are absolutely right about the invisibility of Native American, of Alaska Native and Native Hawaiian communities, right, in the data. If we thought that was true of the other vulnerable populations we mentioned, it is even more so from what we have seen with our Native American colleagues. Now, one of the other issues that we're dealing with too is, you know, there have been institutions that have collected some data in their COVID trackers that pertain to Native American communities, but we know that there has been a backlash by some of the Native American communities who were upset when you talk about data sovereignty and these institutions not respecting data sovereignty. So we are working to ensure that you know, what we are building respects the sovereignty of the data, that we are being as inclusive as possible, and through that effort, we hope to be able to tap into and collect that data. So that is forthcoming. I'll say that in terms of infrastructure, this really gets to the political determinants of health for us, right? And it's a reason for the legal epidemiological data set that we are working. Sometimes we've had to pull our own data because we don't have the data. The public data isn't there to give us that fuller picture. And so we are creating our own data sources, looking at, as I mentioned, you know, issues dealing with health infrastructure, looking at health insurance coverage, looking at policies that you know, were enacted at different jurisdictional levels, local, state, and federal. Again, the idea there is we want to understand which policies have either mitigated the impact of COVID-19 in communities of color and other vulnerable communities, or which ones have exacerbated and why. So we are tracking some of these policies. We've been doing that since the start of the pandemic, and we will incorporate that into our data set. And we're hoping to understand as best as we can what the impact has been to our Native American brothers and sisters, as well as with our Alaska Native and Native Hawaiian groups. I hope I captured everything that you asked. Yes, okay.
Thank you. Thank you so much. So, you know, Dr. Krieger, thank you so much for staying with us through this discussion. Many of the task force members referred back to your presentation as well. I would just like to invite you to make any comment in reaction to some of our discussion.
So one quick comment in relation to particularly the very important issues that were just brought up by Victor Joseph, is that the problems with American Indian, Alaska Native, Native Hawaiian, Indigenous data are huge for lots of things besides COVID. And part of it is it's twofold, because one is who is showing up as cases. It can't just be looked at in terms of the Indian Health Services because of their limited jurisdiction in terms of looking at who are the different Indigenous individuals who are living in many different cities, particularly in California, where you have to start to turn to, that's not going to be covered by IHS data. So IHS is part of the story, but it's only a piece of the story. And that really needs to be emphasized. And there absolutely there's the Urban Health, Indian Health Institute, amongst others. They're trying to figure out what to do in terms of looking at the experiences of people that are not actually in the IHS catchment areas. The second part is the denominators. The census data themselves are highly problematic in terms of what the count is of who gets counted as being American Indian, Alaska Native, et cetera. And there are data linkage efforts that have been funded and that have been innovative within HHS and CDC, and they cost money to do proper data linkage. And if you're talking again, so that you can start to link birth and death records and health records and medical records to start to get a much better sense of who's being counted when and where to come up with stronger estimates. And I think that if you talk to the issues of some of the many emblems of structural racism and in this country, one of which has been the horrific data on American Indians, Alaska Natives, period, as tied to also these questions of data sovereignty and not having the resources to fix it. And that plays out in the health data as well. So this is a chance, I think, to highlight that some, but just to emphasize that this is not just COVID, and it's not just about what is IHS, it's way outside of what is IHS, and it involves also who's going to end up being counted in your denominators, and that really matters. And there is work that can be done, and it costs money, and it takes people. And this is about building up the data infrastructure to prioritize that. And I think one of the things that happens is that there's often a framing that you'll see, well, these are small populations. That doesn't cut it as an excuse not to put in the resources because of what the histories are, the obligations are, the treaties are. It's the same thing that happens in a very different way, separate from the sovereignty issues, which are of course enormous, around occupational data. So that, for example, Mary Turner, you've spoken a lot about the nurses. Trying to get good occupational data on specific occupations should not be so hard. It's crucial. Some occupations may be smaller compared to others, but if they have a really elevated risk because of structural conditions, that needs to be mitigated. And that can only be done if it can be documented.
Thank you. All right. Thank you so much, Dr. Krieger, Mr. Dawes, task force members. Please join me in thanking them in all our virtual ways for really just outstanding contributions to the work. Thank you, thank you, thank you both so much. So we do have a few members. That was fantastic. I think people really leaned in. I wanted to share a few, I think, of my data reflections at this point in our conversation, and certainly invite others to share as well. I found those presentations just immensely helpful as we are getting going in earnest on this work. Data itself, it's so clear, is a deep equity issue, right? All by itself. What we do, what we don't do, what we collect, what we don't collect, the types of data that are available versus where there are gaps, that informs our action, our inaction, quite frankly. Dr. Krieger pointed out the missing data on race and ethnicity and how that contributes to, quite frankly, often a denial and inaction. And I think that important conversation about the contextualized social metrics and ways to really try to capture those structural injustices. And she also spoke deeply to not just the data collection, but also the data analysis, the choices that we make in terms of analytic approaches that we select that really can either highlight or obscure what we call often truth in the universe. We had a very robust conversation again with Mr. Dawes, and I don't want to lose sight of one of the other points that he made, which was around, how data can be misused, right? He talked about racially based algorithms resulting in patients sort of being denied medical care. So a lot for us to consider. Overall, I feel encouraged though. They both suggested, and there are data solutions that are possible. So I wanted to turn to, there are many models out there, but Deloitte offered up a model that I want to share with our group for approaching pandemic data that I think ties very nicely with the conversation we just had. The first point is that the model recommends data are responded to quickly and in real time and proactively, already a theme emerging here. Important, as we've talked about accessibility in so many ways, data should be presented simply, but powerfully in easily understood ways, right? That's how we want to motivate people to make informed choices. We have to use data as a tool there. We also have to think about technology and the role of technology, making sure we can share and increase connectivity across data systems. Something I think, I mentioned earlier, I heard Dr. Krieger mention, and Mr. Dawes as well, is data governance. That is just as important, right? Who makes decisions about how data are used, where data goes, just as important as the data collection and reporting. And hand in hand with that is data privacy and security. As we talk about the need for increased data, we need to also talk about the need for increased privacy and security of those data. And data sharing, right? I think we're already seeing the opportunities for collecting across sectors and doing crosswalking and cross-linking there. And the last part that I think is helpful from this Deloitte model is, that we have to be able to use these data for decisions, right? And I think many of you have already spoken to that. We have to think about things like bias in the data, inconsistency, lack of completeness. And we have to strengthen those data standards, right? We have to be able to harmonize across multiple data sources. So I think all very helpful considerations. I want to open back up again just to frame for our minutes of conversations. If you are anxious to continue the conversation we were having, to share additional perspectives of yours from your own experience with data this past year, and really moving forward, we're going to have to consider and prioritize actionable metrics to drive equity. So what considerations and opportunities do we think should be on top? I will stop my mic. My apology. Let me see if I cannot. My apologies, because I don't know who raised their hand first. I'll call him Mr. Watts, please.
Thank you. I don't know if I raised my hand first, but I know I raised my hand. So just want to share some perspectives about data. And I'm coming from the perspective of someone who's run a federally qualified health center. And one of the advantages of being on this task force making recommendations to the federal government is that those that are adopted will have tremendous power. So the Bureau of Primary Health Care sets out what every health center has to collect. And those that they say have to be collected, they are collected. They have some that are optional that could be collected. And then we see a great deal of variability. So I think one of the things we will have to wrestle with, and I also, as an administrator, you also don't want to put an undue burden, but you have to weigh the cost and benefit of collecting the data. But it's clear we have a dearth of data that is driving inequity because we don't know what's going on, and we need to. So I just really, as we think about the recommendations, realize that what a funder says has to be collected or a regulator says has to be collected will be.
Thank you. Very helpful. Dr. Putnam, please.
Thank you, Madam Chair. I think you brought it up. I think there's an important point here is that the data has to be useful. And I think when you think about it from President Biden's standpoint, or governors or mayors or tribal leaders or healthcare leaders, they have to make several important decisions from that data. So getting it standard, I think, is very key, that standardized process. I think there's also something, and it's possibly down the road for the task force, is the analysis of the data. I mean, turning that data into information and possibly even knowledge might be really what a lot of local leaders need to have. So I think the breadth and depth of everything we've talked about, how to slice this data and capture it, and then by zip codes, so local leaders, state leaders can really make good, solid decisions based on that. I think that's key, and I don't know what order we go in with that, but I think it's that standardization process. It has to be rock solid, garbage in, garbage out, and we all know that. So how do we make it clean? How do we slice it by zip code, and then how do we make it so, just to your point, that it can be assessed and utilized by local leaders to make good, solid decisions for people.
Right, thank you. Mr. Joseph, please.
Thank you. Once again, that information that was provided was just awesome. It was really good. What it laid out for me was basically this, is that, good, reliable data is essential for us and how we're going to be able to respond to this pandemic. The lack of that is been the problem. Access to that information so that we can even check the accuracy of it to make sure what's being reported is being reported right. I go back to some of the comments that Dr. Krieger made, and when she was saying, census data and how census data is being used. But when we look at some of those data points, it's how racism may be being tracked. In some cases, what they have, like on the census, and this was in previous, was if you were American Indian or Alaska Native, you could have checked other. And so you're classifying a whole bunch of other people in an other spot. And so how are you going to be able to drag information out of that to really use well? You start looking at other areas and you start thinking about American Indians and Alaska Natives and IHS information. Well, that's also limited because many of the American Indians and Alaska Natives don't just go to IHS facilities. And then if they ain't identified accurately in other data sets, then that really lowers what you're able to perceive in the data that you're able to drive from. So it's going to be really important when we start talking about collaboration and coordination that we talk about all the entities that have information that's going to be useful for us to take action in and to be able to respond to the pandemic accordingly. So those are some of the areas that it really moved me forward and drove my thoughts on. There's a lot more that I can be discussing on this. It was a lot of information to absorb in a very short period of time. And I hope that there's more time that we get to share privately or just to talk about what is it and start digging down in it a little bit more. Thank you very much.
Thank you, Mr. Joseph. And we will continue these conversations in subcommittees and return to this conversation in future full task force meetings. Ms. Turner, please.
So I'd like to share some of the nurses' concerns about the lack of comprehensive disclosure, transparency, and reporting of COVID-related deaths and infections. First of all, we need accurate data to assess the risk and workplace safety and patient need. As of February 25th, 2021, National Nurses United has found that at least 340 registered nurses have died of COVID-19, and 3,336 healthcare workers have died. Only 1/4 of the registered nurses in the United States are people of color. But based on our findings, our union believes that at least 54% of the RNs who died of COVID and related complications have been nurses of color. I say we believe this is the case because our union has been forced to dig through piles of government reports, news, and other sources, and even obituaries to identify how many registered nurses and other frontline workers have died and been infected. Accurate data is a matter of life and death for us. There is widespread resistance in the hospital industry to track and disclose information about hospital-acquired infections. Hospitals nationwide are still not providing healthcare workers adequate PPE or testing or monitoring of workers and patients. And the failure of federal, state, and local governments to compel them to collect adequate data allows the hospital industry to potentially evade the responsibility of putting our lives at risk. As nurses, we know the value of an assessment, and we know that we need to assess to know the problem first. If we aren't tracking where PPE is going or whether hospitals are consistently giving healthcare workers access to them, how can we know how much PPE to produce and where to distribute it? If we aren't adequately tracking where risk is concentrated and the degree to which cases are going up or down, how can we make grounded policy decisions about public safety and health? If we don't have accurate assessments of disproportionate number of patients and healthcare workers of color who are infected at work and on the front lines, we can't put resources where they are needed. And to truly get an accurate data about hospital worker infections in hospitals, it should be required to provide at least weekly testing of all hospital workers, something that is rarely done by hospitals across the country, even 1 year into the pandemic. Otherwise, especially with asymptomatic infection, we will not know the true infection rate. And similarly, we will not contain the virus. And that's what equity is all about. So what we need is a uniform national data system that would put accurate information into the public domain. It would help us to protect healthcare workers by making sure that medical supplies and resources get to where it is needed most. And it would help us to better track sources of infection in hospitals and in communities so that we can better control outbreaks. Nurses need transparent and clear data information for ourselves and for our patients. Thank you.
Mm-hmm. Thank you. Thank you for keeping our eye on also PPE and testing and all the full spectrum of COVID-19 resources that are still needed. Mr. Venters, please.
Sorry, did you say me?
Yeah, sorry, yes, no, Mr. Venters.
Okay, thanks. Hi, so thank you. I know we're at time. I just wanted to invoke a group of 2 million people, 2 million human beings, people who are incarcerated in this country, people about whom we don't even know the basic numbers of how many people have died from COVID-19. We think about 2,500 deaths in prisons, federal and state prisons. We don't really know and have a clear sense today of how many people have died in county jails and other detention settings. We have about 5,000 of these places in our country. We are pretty sure that the rates of infection among people in these places are higher, with some small studies, but we don't have the capacity. We haven't built the infrastructure to care about the rates of infection that we can see on a real-time basis, the rates of death, and also now, importantly, the rates of vaccination. And so this group of people, their health has been left to law enforcement agencies so that the Bureau of Justice Statistics collects data about death, for instance, but often it's years down the road. Our capacity to respond to a pandemic for the entire nation, certainly for people in the disparities umbrella, these are places that have filled themselves with people of color, people with behavioral health problems, must include the development of structures to know in real time what are the rates of infection, what are the rates of death, and what are the rates of vaccination in these 5,000 places, 7,000 if you include juvenile detention settings. So thank you.
Thank you, Mr. Winters. Mr. Toronzo, please, and then after that we'll have Dr. Calhoun, and then Ms. Yoon and Dr. Martinez will end us.
Thank you, Madam Chair. So as a young person living in South Florida, from my perspective, I've seen how people of color can be disproportionately affected. And through Mr. Dawes' data, I was very surprised to see that an overwhelming number of children that have died from COVID-19 were people of color. And I do believe that it is very important that from now on, we try to push for data to show whether or not children can be safe in schools, especially amidst the new variants that are making their way here to the United States, especially when we're planning for schools grades K through 8 to be reopened by day 100 of this administration. So I really do feel that that is a big issue. And I know that lots of young people across this country want to go back to school and attend any other educational institutions. But, I do believe that we would need the data to show that kids will be safe and that students can return back to school without having to risk their lives, just like the children who passed away from COVID-19 did. Thank you.
Thank you, Mr. Toronzo. I think, we absolutely hear you. The outcome is a rare one, but every life lost, and certainly every young person lost, is one too many. And I think Mr. Dawes did talk about the need for resources, right? And I think that is the idea, is schools have to have the resources for the mitigation. But absolutely, I hear your call for data, Mr. Toronzo. Dr. Khaldun?
Thank you, Madam Chair. Yeah, I just wanted to put a finer point on what many others have said, and especially I think Dr. Krieger brought this up as well, and that is public health infrastructure. As the point and lead for Michigan's response, I have felt throughout the past year that we've been trying to jerry-rig the data response while trying to respond in real time. If we don't have data from a test and it doesn't come in electronically, I would have case investigators who were trying to investigate thousands, sometimes over 1,000 cases in a day, and trying to get information about where that person's been and who their contacts are. And at the same time, because we didn't get that data from a test, trying to get the data around disability and where that person worked and their ethnicity. And so really, when we talk about public health infrastructure, we've talked about this, it's not just technology, it's about personnel, who's going to do the analysis, even if you get that data. It's really, really important that we think about this public health system infrastructure as we think about our recommendations.
Thank you. Ms. Yoon, please.
Thank you, Madam Chair. I also wanted to echo one of the colleagues have mentioned in terms of making sure we connect the data collection with policy design and policy making. So at all levels of government, and in particular, I wanted to emphasize the importance of connecting the data collection we're doing with all the policies we need to make at the federal level to get us out of the crisis, right? This dual crisis of economic recovery and of public health crisis, right? And so much of and thinking about the collection of data in different time horizons of what do we need to do in the more immediate, midterm, and the long term, right? And so that we're really building a much more robust and resilient public health infrastructure, but also our economy. Thank you.
Thank you. I just want to confirm for Drs. Putnam and Mr. Watts that we've discussed your comments. Your hands are still raised. Good. And then Dr. Martinez, you can have the last word, please, in our group discussion.
Thank you, Madam Chair. Really just a comment, because I think it sort of has come up as well, is also about really making sure we're leveraging, it comes to mind, especially when we're thinking about health equity, is also cultural, linguistically appropriate services, the class standards, for instance. Are we shoring and making sure this is a time to really emphasize they must be put into place? Too often I've seen studies that show that we're still lagging in actually standards in ER settings, in hospital settings, as well as even ambulatory settings. Because as I'm thinking about the communities, especially those closest to
Oh, Dr. Martinez, I think you went on mute.
Sorry about that, Madam Chair. Unstable connection, it said.
No problem. The gremlins always get us. Well,
we should make, we are key to ensuring we're getting good quality data, but we're also, did you lose me?
Yeah, I think it's still choppy, but I've got my notes here, Dr. Martinez. Class standards, cultural linguistic standards, we still see the gap and the need there.
Right, especially I'm thinking about the U.S.-Mexico border and other communities where English is a limited, language for some folks.
Perfect, thank you.
Thank you.
Thank you, and I think you are back. All right, wonderful. Thank you, everybody. Incredibly engaging. Lots of notes there. With that, and again, this is not our last conversation. We're going to revisit data all the time. It's core, it's foundational to all our work. With that, I will turn it over to Captain Wu, please, for public comment.
Thank you. So now we have the opportunity to receive public comments. Our first comment is from Dr. Nick Fitzgerald. He's a superintendent of the Canajoharie Central School District in New York State. Thank you for joining us. You can unmute now. Amber? Dr. Fitzgerald, are you online?
While we're sorting that through,
Okay.
I'm just orienting everyone that we're waiting for the technical glitches to work, but we have an opportunity now to hear from members of the general public who'll be joining us by audio.
Okay, well, let's go to the next speaker. We have Ms. Kirsten Baker, CEO of Genie Mobile Interpreting. Please go ahead.
Thank you. Can you hear me?
Yes.
Wonderful. Thank you, Dr. Nunes-Smith and members of the Health Equity Task Force for the work that you're doing to lift up and give voice to marginalized communities and for convening this task force. Its mission is absolutely critical now more than ever. My name is Kirsten Baker, and I am CEO and co-founder of Genie, a mobile technology platform that connects you to video or audio calls with live interpreters at any time of day for on-demand language assistance. Healthcare providers and community organizations across the country are using Genie on mobile devices, landlines, or computers to ensure effective communication during in-person patient visits and telehealth consultations. I've dedicated my career to the belief that language is a basic human right. We founded Genie to eliminate language barriers and to create more equity and justice in areas like healthcare, law, education, immigration, and refugee support. This mission is at the core of our work right now in U.S. healthcare as we help caregivers communicate with all patients, including those who are deaf and hard of hearing, and those who have limited English proficiency. The problem of misdiagnosis and mistreatment in healthcare that results from language discordance has been greatly exacerbated by COVID. This is due to the virus's disproportionate impact on underserved populations, its urgent nature, and the distancing it has forced among people. Jeannie is working with federally qualified health centers, free and charitable clinics, and community health centers, as well as other nonprofits in social services and humanitarian aid, all organizations who have been utterly overwhelmed for the last 12 months at the front line of this crisis and who are now bracing to take on vaccine dissemination. The urgent pain point that drives these organizations to our doorstep is language. Even the best intentioned are struggling to deliver equitable healthcare access and treatment to limited English proficient and deaf patients due to language barriers and the lack of means to overcome them at the point of care and in the moment of need. Imagine for a moment, all of you, that there's no audio on this live stream and that you don't know American Sign Language. You only see mouths moving. That's essentially what the experience is for a limited English speaker when they show up for a healthcare appointment. This is one area where I hope the task force will choose to make a substantial investment in difference. There are many deep-rooted systemic causes of health inequity, which will take time to overcome, but language is one impediment we can solve for today with the tap of a button. The FQHCs and the other federally funded health organizations that will lead the charge for health equity in the administration's COVID-19 response and vaccine distribution desperately need access to on-site interpreting at testing and vaccination centers in order to inform patients, ensure proper adherence to protocols, and to build trust. We ask this task force to design and execute a vaccine dissemination and education strategy that incorporates real-time on-site interpretation at the point of care along with translated materials. Such a strategy will demonstrate the positive effect of language access on diagnosis accuracy, treatment outcomes, cost of care, and overall health in our community. This would better our collective understanding of the impact of language access on linguistically and culturally diverse communities, as Dr. Martinez was just referring to, and better inform public health policy as it concerns issues of health equity and health justice. I greatly appreciate the opportunity to comment today, and thank you again for all the work you do for our communities.
Thank you, Ms. Baker. Next, we have Dr. Harold Schmidt, Assistant Professor at the University of Pennsylvania. Please go ahead.
Hi. So in a way, all I want to do is to continue to jump up and down that such an all-star team has been assembled here, but I won't do that. And instead, I want to flag 3 points on using data in ventilator and vaccine rationing. So in spring 2020, across the country, triage protocols were adopted that aim to integrate objective data in a way that enables fair ventilator allocation. Only in focusing on maximizing overall benefits, dominant models paid insufficient attention to the distribution of benefits. And this matters because the way data were combined means that historically and structurally disadvantaged populations, especially disabled and Black communities, had lower chances of getting a ventilator. Despite major guideline revisions in 2020, much of this guidance remains, and some legally binding, and more on that in the written comments. We are on the whole on a better incidence trajectory now, but we can still not be sure that we can continue not to have to ration ventilators. And guidance carries important expressive value. So it's welcome that the task force will provide recommendations on federal crisis standard of care. And I'll share with the group 6 concrete suggestions colleagues and I recently published on how we can reduce inequitable consequences from reliance on widely used SOFAR score data within dominant triage frameworks, along with the studies showing that we lack data on the views of disadvantaged populations on ventilator triage principles. Now, 2 comments on vaccine allocation. First, on how we allocate vaccines to states. Former Health Secretary Azar explained that allocating vaccines to states proportionate to population is, quote, fair, simple, and consistent, unquote. Only it's not clear that that's so, and that's because not all states have the same number of disadvantaged people. Using the CDC Social Vulnerability Index at the national level, colleagues and I showed that in 16 states, exactly half blue and half red, more than 1/4 of the population are among the nationwide most disadvantaged. So for example, in New Mexico, more than 3 in 10 people are among the nationwide most disadvantaged. But in New Hampshire, just over 1 in 10 are in this group. So allocating by population alone means that disadvantaged groups, and by extension, more disadvantaged minorities, face increased scarcity in states in which they account for a larger population share, But this is not their fault, and it's not fair. It would therefore be helpful if the task force reviewed the formula for allocating vaccines to states and thought about ways of mitigating an equitable impact, for example, adjusting quotas. Finally, colleagues and I carried out several reviews of states' use of disadvantage indices, such as the Social Vulnerability Index. Last year, we found that roughly 1/3 of states use this data tool. And this year, we found half of states use such an index for 4 main purposes that all directly increase equitable allocation. It'd be useful if the task force found a way of enabling states and cities still contemplating using a disadvantage index to learn from their peer leaders. There are countless ways in which we can make real progress with equitable allocation, and importantly, none sacrifice equity for efficiency. And really, finally, a data target that aligns with the recommendation in the national strategy that states should use the SVI or similar index to describe progress towards equitable vaccine access. It'd be helpful if the task force encouraged jurisdictions to strive for vaccine uptakes in ways that there are no differences across the disadvantage index spectrum. This would help simultaneously promote public health, social, and racial justice. I thank you for the opportunity to provide comment and look forward to the important work that this group will accomplish.
Thank you, Dr. Schmidt. Next, we have Dr. Eduardo Sanchez from the American Heart Association. Please go ahead. Dr. Sanchez, are you online? Okay, let's move on to the next person. Next, we have Mr. Narges Shade from Oregon Law Center. Please go ahead. Mr. Shade, are you online? Okay, so if you're not...
Can you hear me? This is Sanchez.
Yes.
And let me start by saying, those of you who haven't figured it out, if you hit *6, you'll be unmuted. So thank you for the opportunity to comment. My name is Eduardo Sanchez. I serve as Chief Medical Officer for Prevention for the American Heart Association. I also lead the association's COVID-19 activities. We are heartened by the White House's focus on health equity. In 2018, the American Heart Association formed an Office of Health Equity, and last November, we released a presidential advisory that examines structural racism as a fundamental driver of health disparities. The COVID-19 pandemic has re-exposed long-standing inequities in our healthcare delivery and public health infrastructure, exacerbating disparities in access to care and health outcomes, as we have heard today. Such great comments and such great speakers. Since the pandemic began, AHA has been working to address equity challenges by providing credible information on COVID for the public and the medical community, and adjusting our research portfolio to establish a $2.5 million rapid research fund to fast-track studies of the heart and brain implications of COVID-19, including studies focused on disparities and underserved populations. We also launched a COVID-19 cardiovascular disease registry that captures real-time data on patient characteristics, treatments, and outcomes for thousands of adults with COVID at hundreds of hospitals across the country. Almost half of the registry is comprised of Black and Latinx patients. Investigators have found significant racial and ethnic differences in prevalence of comorbidities, clinical course, and outcomes. We'd be happy to provide more information on the registry and research findings if that was of interest to the task force. Let me conclude with 4 concrete and short recommendations. 1, the administration should continue to use trusted messengers to talk about prevention and the importance of getting a COVID-19 vaccine and where and how to obtain one. 2, extra effort must be made to get vaccines to those who are least able to obtain them. For example, smaller vaccination sites closer to where people live, or house-to-house vaccination. We are concerned that mega vaccination sites exacerbate disparities. And we feel that the National Academy's framework for equitable allocation of COVID-19 offers principled, evidence-based guidance for prioritizing access. 3, as has been mentioned a number of times today, essential workers still need adequate PPE and environmental adjustments to their workplaces to better protect them. We're not out of the woods. We need some regulatory oversight to make that happen. Lastly, we must invest in and refortify the public health infrastructure. A competent infrastructure, including data and data scientists, is critical to control disease outbreaks and protect health, yet funding remains woefully inadequate. Our public health governance structures must be more inclusive and representative of the diversity of our country and communities. I'd like to express AHA's support for your efforts to achieve health equity and enhance response to and recovery from this pandemic and any future public health emergencies in a strategic, equitable, culturally competent way. Look forward to being able to offer public comment as y'all finalize your report. Thank you so very much.
Thank you. Let's go back to Dr. Eduardo Sanchez, see if he's still online. Star 6 to unmute.
That was Sanchez. That was Dr.
I mean, sorry. Okay. Next, we have Mr. Narges Gabe from Oregon Law Center. So are you online? Star 6 to unmute. Okay. All right. Moving on. If you did not pre-register but would like to submit public comment, please email your written statement to me at COVID-19HETF@hhs.gov by close of business Friday, March 5th. And that concludes the public comments. Back to you, Madam Chair.
Thank you so much, Captain Wu. Thanks everybody for the public comment, very valuable. Thank you to everybody for participating in the inaugural meeting of the COVID-19 Health Equity Task Force. Thank you as well to our ASL interpreters for joining with us for our additional marathon session today. Thank you so much for that. So, you know, I think we're off to a really strong start, right? We are laying out, I think, a lot of what we have to do. We've started our work towards recommendations really on the challenges and the opportunities for collecting and utilizing high quality data to advance COVID-19 equity and so much more. I mean, we are very committed to data-driven work. We will, as I mentioned before, be including data on the agenda for future meetings. So on the short-term horizon, the very short-term horizon, equitable access to vaccines, of course, will be a top priority for us. There is a need to bring substantial resources to bear to promote access, communication, engagement, and outreach to the hardest hit communities. So between now and our next meeting, we will continue our work in subcommittees. The subcommittees will be focused on data, analytics and research, healthcare access and quality, structural drivers and xenophobia, and communications and collaborations. We will report out on the work of the subcommittees at the next full task force meeting, which is planned for late March. The date and time will be provided when the meeting notice is published in the Federal Register and will also be posted on the task force website. So we need to meet this moment. I'm inspired after today. You know, we have to focus on equity in the response. We can't lose sight of long-term resiliency in the recovery and beyond. I know I do. I think all of us do. We want to reclaim our joy. We want to gather in person, right? We want to worship together, have family reunions, send our children to school, reopen our businesses, and to do all of that safely. So testing and therapies and vaccines are the tools we have to get us there, and access has to be equitable. We have to work to disrupt the predictability of disproportionate impact in select communities during times of national crisis. That is a must. So I look forward to the work ahead with each and every one of you. Thank you so much for your service. With that, we are adjourned.
Thank you.
Thank you.